Hello everyone, I am Shahtaj and today we will be discussing Barrett's esophagus. Now, Barrett's esophagus is seen in long-standing chronic cases of GERD. It is actually a complication of GERD and it refers to metaplastic changes of the epithelium. Normally, the esophagus is lined with squamous epithelium and its conversion into low columnar epithelium is what we call as intestinal metaplasia. Now, this means that this metaplastic change is an adaptive response to acid in the esophagus. Along with the change in epithelium, there is also presence of goblet cells, and this is the pathognomic signs of Barrett's esophagus. Other than long-standing chronic GERD, we can have other risk factors associated with Barrett's. These include men, greater than age of 50, obesity, sensual types, and cigarette smoking. Now let's discuss the progression of Barrett's. Intestinal metaplasia was actually Barrett's. In cases of long-standing Barrett's, it can develop to low-grade dysplasia, then to high-grade dysplasia, then giving rise to adenocarcinoma. Metaplasia is a reversible condition. However, dysplasia and adenocarcinoma remains irreversible. This means that we can say that Barrett's esophagus is a pre-malignant condition. Development of adenocarcinoma depends on duration and severity of reflux. Let's also discuss dysplastic changes. These dysplastic changes are actually common in all the pre-malignant conditions of the body, and it is important that we remember them as it is going to help us in other pre-malignant conditions as well. We have cellular pleomorphism and nuclear pleomorphism. Now, pleomorphism means a variation in shape and size. We are going to have increased nuclear to cytoplasmic ratio, hyperchromasia meaning a dark staining nucleus, increased mitotic figures, and then we can also have architectural distortions. So these are the dysplastic changes that are going to give rise to adenocarcinoma. Now let's look at a picture to summarize whatever we've studied so far. So we can see here that the stomach is lined by glandular epithelium and the esophagus is lined by the squamous epithelium. Both the epitheliums meet in a region which is known as the squamocolumnar junction, also known as the gastroesophageal junction. When we have GERD, it leads to reflux esophagitis, if you can recall from the last video. And reflux esophagitis is when mucosal injury, you can see that there is a mucosal break, a mucosal injury, and this leads to activation of the inflammatory cascade. With time, when the inflammation subsides, it leads to the repair process. However, in cases of long-standing GERD, we can see that there is going to be transformation of the epithelium, which was known as intestinal metaplasia. Right? This change in epithelium first begins at the gastroesophageal junction. Now, it is important to remember that any change would begin at the gastroesophageal junction, and then we can see that this is the Barrett's segment. With time, it is going to develop into a full-fledged glandular phenotype, and then the process of GERD is going to move proximally, which means that after it has involved the gastroesophageal junction, it is going to move proximally upward, involving the upper parts of the esophagus, which means that it progresses. Summarizing that after long-standing GERD, Barrett's esophagus is a pre-malignant condition that first leads to intestinal metaplasia, followed by low-grade dysplasia, high-grade dysplasia, and then eventually giving rise to adenocarcinoma. Let's also discuss the clinical features associated with Barrett's. Since it is seen in chronic cases of GERD, the patient most commonly presents with all the symptoms of GERD that we discussed in the previous video, such as retrosternal burning sensation, water rash, regurgitation of food. However, in very few cases, rarely, a patient may present with silent features, which means that it is an incidental finding. However, presenting with GERD is going to be the most common feature. Moving on, now let's discuss the types of Barrett's esophagus. We can divide it into three classifications, which is based on the length of the Barrett segment, based on the degree of dysplasia, and based on the histological subtype of columnar epithelium. We will be discussing each of them in detail. Let's first talk about the length of the Barrett segment. So according to the length, it can be divided into short segment and long segment. So short segment is when there is less than 3 cm of intestinal metaplasia above the gastroesophageal junction. So it is important to remember that the length of the Barrett segment will be calculated directly above the gastroesophageal junction, and there is going to be a decreased risk of progression to dysplasia and adenocarcinoma in short segment, whereas long segment is greater than 3 cm of intestinal metaplasia and the risk of progression is higher in long segment. Now, how do we calculate the length of the Barrett segment? It can be calculated through endoscopy, and this is known as the Prake's classification that measures the circumferential extent and the maximum extent, which is the length. This is what we are concerned with. Let's discuss a few basic pointers. We insert the endoscope and identify the gastroesophageal junction. And how do we identify it? We look for the proximal gastric folds, and we also look for the Z line. The Z line, which was the squamocolumnar junction. After that, it is important to note that in cases of hiatal hernia, where we discussed that the gastroesophageal junction was moving proximally upwards, we have to identify the hiatal hernia first, and then we have to identify the new gastroesophageal junction. The gastroesophageal junction is normally located 40 centimeters from the incisors. However, this is not a benchmark. Let's also discuss it through a few pictures. We first identify the gastroesophageal junction, which is marked as the origin point at 0 centimeter. We then take the circumferential extent of the metaplasia, which is the total diameter involved. And then we take the maximum extent of metaplasia, which is again the length. And then in cases of hiatal hernia, we first have to recognize the hiatal hernia, and then we have to correctly identify the gastroesophageal junction, then take the total circumference of the esophagus involved, which is going to be the entire diameter involved, and then the maximum extent. This is how we take the length, and then we can divide it into either a short segment or a long segment, depending if it is less than 3 centimeter or if it is greater than 3 centimeter. Now let's discuss the second type of classification, which is based on degree of dysplasia. We've already discussed this, but just as a quick revision, it could be non-dysplastic with intestinal metaplasia only. It could be low-grade dysplasia that shows mild atypia with a preserved glandular architecture, or it can be a high-grade dysplasia with marked atypia, glandular distortion, and highest risk of cancer. We've already discussed features of dysplasia in the previous slide. Based on the histological types of columnar epithelium, this is usually an obsolete classification, but let's still discuss it. It can have the specialized intestinal type with goblet cells. We already discussed that this is the most common, and this is also known as true Barrett's. Then we have the gastric fundic type with parietal cells, and then we can have the cardiac junctional type with mucus secreting cells. This is all about the classification of Barrett's esophagus. Since we already discussed this, that this one would be seen on endoscopy, we will be discussing the endoscopic findings later, and these two, of course, will be seen on histopath samples. Now let's discuss the diagnosis of GERD. The diagnosis is first going to depend on an appropriate history. Obviously, the patient is going to give history of chronic GERD, where the patient will experience regurgitation and heartburn. And all the risk factors that we discussed would be positive, which include men greater than age of 50. It could be associated with obesity and smoking. The investigation of choice is going to be an upper GI endoscopy. This is also the gold standard. On upper GI endoscopy, we are going to see a salmon pink to red velvety mucosa. We can see here in the picture as well the pink red mucosa. It is a red region that extends proximally, which means that the squamocolumnar junction is displaced upwards. Now let's try to understand this, because we discussed this in hiatal hernia as well. So sliding hiatal hernia and Barrett's esophagus looks similar on endoscopy. Let's try to understand it. They look similar because in both the conditions, the squamocolumnar junction, the Z line or the gastroesophageal junction moves proximally upwards. In Barrett's, it moves upwards due to intestinal metaplasia. And in hernia, it moves due to proximal displacement. Now let's try to understand it through this picture that I've made. That in intestinal metaplasia or in Barrett's, if this was the old gastroesophageal junction, due to intestinal metaplasia or change in the epithelium, the new gastroesophageal junction may appear at a proximal end. However, in hernia, we know that through the diaphragmatic opening, if this is the diaphragmatic opening, the proximal stomach and the lower esophageal sphincter is going to move proximally upwards into the thoracic cavity. Hence, they look similar on endoscopy. But how do we differentiate? There are a few differentiating features. The two most common are gastric folds and palisade vessels. Now, gastric folds, let's look at a picture here, that these are the normal gastric folds. Now, these gastric folds usually end at the gastroesophageal junction because they are present in the stomach. However, in hernia, when the proximal stomach is also moving upwards, on endoscopy, the folds are going to be visible, which are not normally seen on esophageal endoscopy. However, in Barrett's, it is going to be smooth columnar mucosa without folds. The palisade vessels are usually present in the lower esophagus. Let's look at a picture here. These are the palisade vessels. These are tiny blood vessels that are actually a distinguishing feature of the gastroesophageal junction. Let's ignore the spelling of the gastroesophageal junction. I'll correct the spelling. So in hernia, they are going to be absent. However, in Barrett's esophagus, they are going to be present. So this is all we need to know about this particular pointer that I discussed. After visualizing the mucosa in upper GI endoscopy, we are also going to look for the Barrett's length as per the Prague CNM classification. With upper GI endoscopy, we also tend to take biopsy samples. Biopsy follows a Seattle protocol. For initial endoscopy, we take the length of the calculated Barrett segment. Let's say that the Barrett segment was 8 cm long. Starting from here, we are going to divide the Barrett segment into 2 cm distance. And at every 2 cm, we are going to take biopsy from 4 quadrants. Now, what are these 4 quadrants? Let's say that this is the esophageal lumen and this is its circumference. Let's draw the circumference here. We are going to take the biopsy sample from a 12 o'clock position, from a 3 o'clock position, a 6 o'clock position and a 9 o'clock position. So let's write it. 12 o'clock position, 3 o'clock, 6 o'clock and 9 o'clock. So this is going to be the standard rule for taking the biopsy at the initial endoscopy. Now let's talk about the results of the biopsy samples on the next page. The treatment of Barrett's depend on the biopsy results, and these could be of 3 types. We could have no dysplasia, we could have low-grade dysplasia, or we could have high-grade dysplasia. If no dysplasia is detected, then we treat it with proton pump inhibitors and suggest lifestyle management. Surveillance is after every 5 years, and the biopsy samples are taken at every 2 cm distance of Barrett's length, like we discussed in the initial surveillance. For low-grade and high-grade dysplasia, we have endoscopic treatments, and these could be of 2 types. We could have endoscopic ablation and endoscopic removal. Now, endoscopic ablation is usually preferred, and it involves the ablation of the abnormal mucosa. It could be done via 3 ways: through radiofrequency ablation, which is usually the preferred method, due to decreased rates of strictures. Other modalities include photodynamic therapy and argon plasma photocoagulation, whereas endoscopic removal is only done in selected cases where we have a visible nodule or a raised lesion. And it could be done via 2 ways. We could have endoscopic mucosal resection, where the abnormal mucus lining is lifted and removed, or it could be through endoscopic submucosal dissection, where the mucosa and the submucosa are both removed, and this is an en bloc type of resection which means that a large area of tissue is removed in single piece. Let's wrap up the topic by talking about the surveillance of low and high grade dysplasia. So for low grade dysplasia, the surveillance period is after every 6 months, and for high grade dysplasia, it is after every 3 months. Since we have already removed the abnormal mucosa, or we have ablated it via endoscopic treatments in both low grade as well as high grade dysplasia, we perform surveillance to check if Barrett's has recurred. And if it has recurred, then we have to do biopsy, and the biopsy sample is taken at every 1 centimeter distance of the new Barrett's length as compared to the 2 centimeter distance when no dysplasia is present. That's all regarding Barrett's esophagus. We discussed its risk factors, its clinical features, its progression, its types, its diagnosis, and then the treatment modalities available. Thank you so much for watching.